Good morning, everyone. I'm Evan King with CalAIM Solutions. Thank you all for joining us today. We're really excited to take this time to talk about CalAIM, as well as the technical assistance that's available to support organizations in moving forward with developing infrastructure, planning, integration, and overall adopting the available benefits through this program. Even though we're more than a year and a half into implementation, there's a long road ahead of us, a lot of lessons learned, and as we've been talking with health plans and providers and community organizations over the past year and a half, and even prior to CalAIM, really felt it'd be a good pivotal opportunity to talk about where things are at today and what are some of the opportunities that might still be available that might get folks excited to further engage in the program and leverage these benefits for their members overall. So that we'll go to the first slide here. So just briefly, again, Evan King, I'm principal and co-founder with CalAIM Solutions based here in Southern California. I work with a range of organizations between payers and providers, really focusing on value-based care and how we help organizations understand the requirements to be successful in those models and how they really engage in a collaborative way to make sure that they have the right infrastructure and capabilities to manage population health across all lines of business. I began work really in the clinical setting, helping to develop a care model for high utilizers of care in the underserved communities here in East LA and also in parts of the East Bay and Central California. Over the years, have had a chance to work across a number of states through Medicaid waivers, as well as federal reform, to really think about how we can again drive better quality and outcomes for populations that are underserved, but as well as all lines of business. And with that, I'll pass it over to Carlene to introduce herself.
Good morning. My name is Carlene Zink. I'm a registered nurse, current principal and vice president of the medical management service line business here at CalAIM Solutions. I have been a nurse for over 35 years with all my experience servicing the underserved and the underinsured in public health ICU, public health hospital ICUs, and the managed care organization for government services. Looking forward to our conversation. Garrett?
Hi, good morning, everyone. My name is Garrett Tedesco. I'm the director here at CalAIM Solutions for our value-based care side, and really excited to talk to a lot of folks here. A lot of these people here are former coworkers, colleagues, and a few bosses on there, so I appreciate everyone jumping on, and nice to see you in there. My tenure in healthcare surrounds all of our networking and provider side, pretty much all through health plans, IPAs, third-party administrators, senior broker sales, and also a former adjunct professor for the California State University system, teaching healthcare administration courses in their graduate programs. So very excited for our presentation today and to hear you guys' questions and feedback at the end.
A little bit of housekeeping for those of you that are new to Teams. Hopefully it's not causing too much trouble today. But if you're in the platform with us, you can enter your questions in the Q&A button. If you look at the top of your screen, there's those two bubbles highlighted here in yellow. You can enter questions there, and we'll address those at the end of the discussion. Likewise, you can email questions directly to info@calpelsolutions.com. After this session, we will send out a PDF of the presentation and a link to the recording, as well as a written summary of the Q&A for the presentation. And then lastly, a brief survey that will ask for your input overall as well. So appreciate you all joining today. And again, if you have any questions, feel free to put them into the chat and we'll address them towards the end. Thank you. Next slide. So briefly for today, a little bit of background about ourselves. We'll do some about CalAIM landscape, again, where we are today, what's to come. We really want to hit on, again, the CalAIM funding and the benefit it can provide to organizations that are either already in the process or considering engaging in CalAIM. We know a lot of folks are thinking about this and what it means for their patients and for their business plans as an organization. And again, how can we leverage that funding to improve performance, quality, population health, outcomes for patients, but also how it can help improve performance under value-based arrangements with our managed care plans, particularly around quality and HEDIS scores. And then we'll wrap up with some Q&A. We can go to the next slide. We'll go one more. So a little bit about ourselves. So CalAIM Solutions is a tech-enabled services firm that focuses on helping organizations be more successful in risk arrangements, both through capabilities, but also through workforce development. Over the years, 20 plus years, we've worked nationally, again, across all lines of business, helping organizations really think about their long-term strategy of how they're going to engage in value-based programs, again, with payers as well as federal and state-based programs, and to make sure that they can optimize those programs and resources to build those capabilities to better serve their populations, engage their providers, and develop the right teams to drive that work. I'll share very briefly, in our founding, we were based here in Los Angeles, started about 20 plus years ago, really focusing on how we help improve access to families, underserved community members, and underinsured. Well before ACA, in California, and particularly here in LA, we had over 25% that were uninsured. And so our roots are really in how do we help improve access to care, sustainable models of care for community providers, and then moving that towards making sure that patients are able to get timely services to address their needs, not just in the clinical setting, but in the social setting as well. Over the years, as our model has evolved, our mission and values have really remained the same in terms of how we want to engage with providers, enable them to be successful in these programs. Next slide, please. As a firm, really focusing on 4 areas. So like a lot of groups, providing traditional advisory support, helping organizations around thinking about what is their roadmap for value-based care, how they might, for instance, redesign care models to be effective for programs like CalAIM. So as regulatory and payment reform are occurring, how we take those policies and opportunities to translate that to how does that then impact our clinical care models, our operations, and our processes on the ground? So really kind of going from policy at the top end down to implementation, again, the front end lines. Implementation support. So again, based on the strategies that we define with our clients, I think we feel a real responsibility to ensure that we develop strategies that are realistic and take into consideration the current capabilities of the organizations we assist. And so we like to see those strategies through to implementation, making sure that there's clarity about what are the key capabilities we need to have in place over time, how do we engage, whether it's the right vendors or support services, so that we can better manage overall population health for these organizations, as well as engaging with payers and workforce development. And so that's part of our commitment, is making sure that we develop those plans and help see through implementation as well. And then, of course, bringing to bear, likewise, a combination of platforms and proven tools. So one of the things that we're excited about is having experts like Carlene, who have been in the industry for decades and who know the space and have been on the provider side or on the payer side and understand what it means, for instance, when something like CalAIM is launched and what that means to translate that again back to operations and provide the right tools that will enable providers to better understand and utilize and access those services to benefit their populations and drive better quality and financial performance for those programs. Go to the next slide, please. All right, CalAIM landscape. So one of the things that, again, we want to thank you all as you signed on. We asked one question about where are you at today in your CalAIM journey? Are you already contracted for CalAIM and off to the races? Are you exploring CalAIM? I have no idea what CalAIM is or other. And I'll say that we have a fair cross-section. We have a combination of payers, public agencies, as well as providers, community organizations, and other stakeholders on the phone with us today. And I'd say it's a pretty even split. About a third of the folks on the phone today are exploring CalAIM. A good portion are likewise on that path already, and some are just learning about the topics, which is perfectly okay as well at this point. And so we wanted to be mindful and to balance our conversation to help address some key questions for those groups. And ideally also think about, again, what's the push we can make to really begin and continue to move forward with implementation and making sure that organizations are successful in adopting the benefits that are available to them through CalAIM. Currently to date, through 2022, if folks haven't seen, the state has seen about 100,000 individuals who have been enrolled in ECM services for the first year of CalAIM. So it's a great stride out of the gate. Again, you all know some of the challenges of engaging the population, screening and enrollment. And I think we've had a lot of lessons learned along the way. One of the key things that, again, those of you who have been in the CalAIM space over the past year and a half is that the value of making sure that we're having a bottoms-up approach, how identifying these individuals in the community, helping to screen, helping to document, and referring them for services so we can begin to capture those folks in the community that aren't just the ones that perhaps health plans are providing to us in their list as well. In terms of community supports, there are about 36,000 members across California who have received over 80,000 services in the community supports area in the prior year. For those that aren't familiar, ECM is also known as Enhanced Care Management. That's really the tailored community-based model where we're engaging with members and trying to really help them create care plans around their needs for populations that are most often underserved, if you will. And that is a core model to making sure that we're able to extend that care management and that reach to help coordinate care across a myriad of services in the community. Community supports, on the other hand, formerly known as in lieu of services, are really designed to address those health-related social determinants. So what are the services that our patients need to address their non-clinical needs that will enable them to better engage in their own healthcare? And so we're excited that the state is, again, providing both of these services, again, outside of the medical premium, so that we have additional resources, both for providers that have attributed populations, but also for community-based and public organizations to really drive these services. Today, we're going to focus primarily on enhanced care management and community supports and what those mean for providers. But as you can see here, overall, CalAIM has a number of areas of focus, including integrating care for the duals, focusing on justice involved, as well as overall population health management infrastructure, which is just now launching statewide. And so we're excited to see these things come together for the community. The next slide, please. So types of funding available through CalAIM. And again, if you're new to the discussion, we thought it'd be a helpful primer to take a step back and look at what are the various funds available. And again, there's probably even a few additional areas beyond this, but we want to kind of think about the layers of funding, if you will. The circles are not intended to show how many dollars are available per area. It's really meant to say, look, what are the layers of what we might want to access and how these are beneficial to providers overall. At the bottom, the first one here is, again, those ECM and community support services. This is really kind of the first area of focus, right? So providers have the opportunity to either directly provide these services or contract or collaborate with community agencies to deliver these services. Health plans are the primary vehicle for these services that are provided in a myriad of funding. ECM services tend to be paid on a PM basis per member. There is one exception in the state where it's a fee-for-service basis. Community supports, given the range of services, could be, for instance, on a per diem basis, a PM basis, a one-time payment. But again, generally speaking, these are outside of the medical premium, so bringing new dollars to the table that really will hopefully help us engage and provide support to those members. So that's really the foundation. As you all can appreciate, implementing these programs takes a lot of work, combination of planning, collaboration with community partners, and development of infrastructure. So what the state has done to support this, they've put into place what is called the Incentive Payment Program, or IPP, which is driven through the managed care plans and really designed to help achieve scale as well as overall infrastructure for these programs. And managed care plans are being charged with this responsibility by the state to make sure that we have measurable and tangible progress. For those of you in CalAIM, you're very familiar with the quarterly reports demonstrating how we've either increased workforce capacity, we've implemented key processes to better engage and screen members or track and manage data for those members. Those of you that aren't familiar, again, this is something that's exciting that the state is really investing in, and these funds will continue to be available through mid-next year. The next layer up is PATH funding. What PATH stands for is providing access and transforming health. This is an additional $1.8 billion. It's available over 5 years. And really what it's intended to do is to provide additional support for organizations that maybe in varying places with relation to CalAIM implementation. If, for instance, you're an organization that is exploring CalAIM and, hey, maybe I want to contract with a health plan to be an ECM provider or community support provider, these funds are available to help out with that planning process. They can also close gaps around infrastructure, design work, workforce development, and training. How the states wants these funds to be utilized is that first is make sure that you are engaging with your managed care plans on your ECM and community support strategy, access those IPP dollars, and then these technical assistance funds through PATH can be utilized to either close some of those gaps where funding wasn't sufficient to cover all the needs, or if there are some targeted needs. What's important here is the state wants to make sure that we're not double dipping though. So again, if we're being funded for infrastructure and planning for one capability with IPP, the PATH dollars can help provide funding to kind of close gaps or supplement what's already there. Next level up, and one of the programs is just now launching, and we'll be sharing more information after this webinar as well, is the Equity and Practice Transformation Provider Directed Payment Program. I know it's a mouthful. This is $650 million over 5 years, another part of CalAIM, and this is really designed to help community providers, independent practices, really be able to engage in practice transformation over a long term, a 10-year period. And what's exciting about this model is that, again, the health plans are going to help facilitate this process on a county by county level so that across the state, we have a common view of who's engaging, how we're organizing, and having some common milestones. There is a commitment as part of this program to commit to certain learning activities, training programs, and implementing processes. And again, much like IPP dollars, these dollars are tied to performance and achieving key milestones. What's important to know is that for this program, there is an application deadline that's October 22nd. So again, be on the lookout for these announcements. The state has already released the application. And for folks that haven't seen it already, it's really helping you take a baseline assessment of what are my current capabilities relative to population health, engaging populations, and practice transformation. Their goal is to make sure that these funds are tailored to help those organizations make that transformation. So how do they incrementally help you make those steps towards being more ready to manage value-based programs and engaging in the delivery of services for these populations? And then lastly on here, another benefit being provided is the community health worker benefit, which is available to individuals who might need that little bit of extra boost, if you will, around disease prevention or navigation for healthcare or understanding their treatment and engaging in services. The nice thing about the community health benefit is that licensed providers can prescribe, if you will, this service to their members. It doesn't require enrollment in ECM, if you will, the same rigor, if you will, in terms of eligibility. So it's a broader program meant to really provide a benefit to community providers to say, look, you know, my patient could use a little extra help in between visits or navigating the system or understanding their needs. And so this is a wonderful benefit that, again, is available to providers to provide to their patients in the community. We wanted to share this because, again, there's a lot of funding coming out in CalAIM and a lot of services. And again, if you folks aren't aware, these are great opportunities to utilize these benefits that are outside of the premium dollar, new resources being brought to bear that you can really use to help impact the ability of patients to access the right services and likewise drive quality for those individuals. Okay, next slide, please. Very briefly, populations of focus. So if you're not aware, CalAIM has a number of populations that the state wants us to focus on. And as you can see here on the left, it's really kind of a rolling timeline, if you will, through 2024, in which the state is going to expand eligibility and access to services for additional populations. In 2022, you can see really the initial focus was primarily on adults. And then as we moved in 2023, beginning to engage the pediatric population. And then lastly, moving into individuals transitioning from incarceration as well as birth. And so we can expect to see here out of the first year, kind of a heavier spread, of course, in individuals experiencing homeless, substance abuse disorders, and that are at risk for avoidable utilization. We, of course, expect to see greater adoption across populations over time, but today it was really helpful to see a nice spread across those populations early on. Next slide, please. So one of the things that we thought was interesting in the data so far is that in the first year, in terms of who is engaging in enhanced care management services, the state put together a summary of the organizations by type and how many are engaging in these services. So first and foremost, we're excited to see a rapid adoption uptake of these services. And we know that, again, there's a lot of work to be done in between organizations in terms of developing collaboration, standard workflows, data sharing, and feedback loops to make sure that as ECM providers are engaging with these patients, how are they able to include, for instance, primary care providers in this process, but also making sure that we're developing mechanisms to share information in terms of, hey, I had a referral from my patient, did they get that service? So that, again, we can make sure we're updating those care plans. What you can see here in the chart is that at the top, federally qualified health centers are kind of leading the charge. And again, probably because these services might be most in line with their current operating model, the fact that they've had community health workers or promotoras in their settings for the past years. And so this was really a nice boost, if you will, to provide additional funding that would allow them to take on a really lead role in enhanced care management. Below that, about 3 rows, we can see that, for instance, primary care providers and hospital or hospital-based groups haven't quite gotten to the same rate of adoption. We think partly because this is a bit newer to them in terms of engaging in a community-based type of program. But again, what's nice about this is that you yourself as an organization don't have to provide these services directly. You're able to contract with or collaborate with ECM and community support providers in the community on behalf of your patients, which I think is obviously, again, a great benefit. So we wanted to share this so you can see, again, kind of the cascade of who's engaging, and it's exciting to see the cross-section and adoption thus far in the year. Next slide, please. In terms of overall enhanced care management services, again, you can see here the adoption. We know that we came into CalAIM with individuals rolling out of whole person care into enhanced care management. So just under 80,000 members came to start out of the gate. And over time, we saw almost about 30,000 additional enrollees over the past year. And so again, that's a steady increase, and it's very positive to see that the process is working. We know it is challenging. These aren't individuals that are easy to find, for instance, that are typically sitting in front of us in the clinics, but we're excited to see the progress. And really it was nearly a 40% growth in just the first year. One of the key things that we saw likewise again is, and excited about, is that individuals that are at risk for avoidable hospital need utilization were one of the highest utilizing groups, followed by those that either had a substance abuse or mental health illness, which again, if folks were looking at data as we were going through COVID and coming out of it, we saw the instances of mental health almost doubling in a lot of populations. And so we're excited to see that we're expanding access to those services for these individuals and for these populations. And again, as the populations of focus expand over the years, we'll be able to provide these services to an increased proportion of the population. In terms of total population that's eligible, as we've talked with health plans, early on in CalAIM, the state was envisioning that maybe 2% of the population might be eligible. But as we worked with health plans and talked with community providers and looked at their data, what we're seeing is that it's often at least 10% of the population, and sometimes higher than that. And so again, this is really a great opportunity to provide services and support for not just a small slice, but a pretty good portion of individuals to help close social care gaps, drive quality, and provide the ability to engage them in services that will help benefit their overall outcomes and health in the long term. Go to the next slide, please. So key considerations that, again, we wanted to share as we think about the CalAIM initiatives. First and foremost, an area that has created some confusion over time, and we thought it'd be worth touching on here, is managed care attribution. And so if you are a provider group that has attribution from a managed care plan, whether it's a value-based or risk-based agreement, and you have those members you're responsible for their healthcare, their medical spend, one of the important things to understand is that as that provider, whether you're an IPA, an FQHC, or you could be a health system with institutional risk, you have the ability, if you choose, to directly deliver those ECM services, engage your members, and enroll them for those programs. At the same time, if that's not in your current capacity or not maybe in the business plan, you can likewise contract or collaborate with ECM providers in the community on behalf of your members. What's also important is kind of the flip side. If, however, a provider that has attributed members chooses not to provide those ECM services, those members can be serviced by other ECM providers. So again, it's not by default that these members will be assigned to you as if you go down the ECM path. This is really something where the state is working with managed care plans to make sure these individuals, of course, looking to maintain continuity of care, but at the same time, if those individuals that have attributed membership aren't picking up and driving ECM services, other organizations can do so on your behalf. And so there's really a good opportunity and call to action to make sure that you're talking to your managed care plans to understand who are the ECM providers in my community, who might my members be attributed to, and that way you can begin that process of collaboration and coordination. Because ideally, over time, we want to build those muscles where ECM and CHW services and referrals for community supports are becoming part of the daily work, as it is, again, a long-term benefit. And then lastly, managed care plans are the organizations in each county that are going to contract and are contracting for ECM services with those providers and oversee enrollment. So again, it's really key that as individuals are screened, found to be eligible, and enrolled, managed care plans are the ones that have that information and are the ones that oversee that overall process. And so as you're thinking about this opportunity and want to understand more about who are the providers in the community, managed care plans are the best source of that information at this stage. In terms of quality measures, one of the things that we're excited about is how ECM funding can support enhancements, financial sustainability, and scaling of current programs. So for instance, prior to CalAIM, of course, there were high-risk clinics, street medicine programs, promotora programs being extended by a number of providers in the community and across the state. And what's nice is the CalAIM funding provides an additional source of resources to help scale and enhance those models of care and make them more sustainable in ambulatory and community settings. The second area, of course, is the ECM and IPP dollars themselves are really, again, outside of the medical premium and really designed to help reach those hard to reach members, which includes duals. And the nice thing is as we engage in this process and build these relationships and develop this infrastructure, it has the ability to provide that benefit to the broader population, right? So as you're building the ability to stratify your population, to make referrals for community supports, to better manage data, to share care plans, all those infrastructure components can be utilized across payers, across lines of business to really have that overall population approach. And then lastly, in terms of CalAIM as an engagement tool between ECM, community supports, and community health workers, these initiatives are really providing the means to engage the members in between those clinical encounters or folks that maybe haven't been seen, in the prior years or years. This helps us to really make sure that we're able to extend that outreach and be able to place resources out in the community, finding the individuals where they are, whether it's in the home or on the street, and making sure we're able to help them come back into care and receive those services. And again, the last thing that we've talked with managed care plans about over the past couple of months is, while initially when CalAIM first started, one, there was a bolus of individuals from whole person care, but then in new communities where there wasn't a whole person care pilot, managed care plans kind of kicked off the work with, hey, these are individuals who we think are eligible, and provided those lists to ECM providers, but recognize that sometimes those lists aren't ideal. Maybe they don't have current contact information. And so really we recognize the need for a strong pivot, which is the bottom-up approach of how do we engage individuals where they are in the community? Maybe they're not on the list already, but how do we begin to screen, to document, and to go through that process so we're able to really identify those individuals who benefit from these services, engage them in the program, and then work to get them enrolled and approved by the managed care plan. And so again, we're excited to see that there's been this increased focus on trying to improve awareness across the community and making sure that if you're not an ECM provider, you're thinking about reaching out to the managed care plans to understand who might be those groups in your community so that, again, you can provide access to those services or be part of the process to screen and engage individuals who may be eligible for these benefits. Next slide, please. All right, I'm going to pass this off to Garrett.
Perfect. Thanks, Evan. So I'm going to do my absolute best for us to, for me to stay on time with my slides. For those folks who have crossed my path prior, to never trust me with a hot mic or in this remote world, a muted audience. So I will do everything I can to make sure that we get you the deep content quickly. So Evan had described essentially how the full CalAIM landscape came to be and where we're sitting now within the CalAIM process. Now I'm just going to touch base on how and what does that actually mean for you guys. How to engage CalAIM with the ECM services, which members you're going to be involved with, and then all the entities that kind of surround the CalAIM process. So this slide here, you can see our spider demonstration and graphic that really describes all the eligible entities that kind of fall within the CalAIM process. So you can see we have essentially every aspect of our industry here, from our hospitals to our delivery systems, our FQHCs, our behavioral health entities, our IPAs, health plans, our public entities, and our CBOs. So essentially what's happening is the CalAIM process is really encouraging and enable that cross-sector partnership, which I know in the past and historically we're always trying to close that gap. Of the aspect of making sure that all of these entities are communicating and collaborating effectively, efficiently with member care down to the center. But at the same time, making sure that we're doing it in a way that makes sense and in a way that is, most beneficial to member care, down to making sure that we're coding appropriately, and down to making sure that, of course, compliant and within the state. So the collaborative effort encourages entities to enhance their care coordination. And what that looks like is that it helps develop the standardized workflows, care protocols, data sharing, referral networks, and essentially feedback loops. So within all of those different structures that Evan talked about, that's essentially what's going to be built. We want to help to build that infrastructure to make sure that this is a sustainable program for you all after, we may see CalAIM, vanish in the future. Obviously not anywhere soon or anytime soon. But, the program and this waiver is just to really make sure that we can get everyone up and running and have that cross collaboration with all those pieces. On the next slide, I'm going to touch base on essentially what partnering with those care community partners and organizations looks like. I know there's a handful of clinicians on the call. Please, no offense to the cartoon. It's strictly, we understand, especially myself, prior life sitting inside of an administrator of the employed provider groups in Optum. I have seen the administrative burden placed on our physicians and essentially what that looks like and the amount of work that they have to absorb and really triage and figure out when to and how to best manage that level of workload within delivering patient care. So what we're doing to find the right ECM provider obviously has going to have a direct access on members and engagement in the program. So one of the pieces of this program is to co-develop screening and surveys alongside of our entities to make sure that we're utilizing and engaging the members appropriately, identifying the social determinants of health, and those gaps to really inform and drive care. Of course, then we always have the wonderful coding on the back end. So with all these new and growing list of Z codes, the integration of those Z codes inside of the care practice down to inside of how we're going to communicate that back to the health plan, how we're going to keep all of our folks engaged and online with having the same level of documentation, and then closing those gap measures. Obviously that's a huge component of what we want to spend time on is the gap closure in every aspect of the care coordination aspect of the CalAIM aspect. And so it's a big piece of making sure that we can connect those dots between the CalAIM entity, the health plan, the delivery system, down to the community health worker who's in front of that patient, helping them find the resources and find how to best utilize their resources inside this big, gigantic system. The next piece and the last one that I'll talk to on this slide is the integration of the SDOH into risk stratification. So this ties into, of course, making sure that this is a critical component of documentation and education from the patient perspective all the way up to the health plan. So we know there's a large gap between health plan membership that's getting passed down into the delivery care system of these providers, and then making sure there's collaboration there so the health plan can best align strategy to these providers to help with their provider support, to help to make sure that provider engagement is high, which will also downstream into the member engagement. So you can see that everything really looks like that spider diagram that we looked at before, where everything has that connection point. This CalAIM process is kind of the octopus sitting in the middle with their tentacles running around, trying to pull all the data and making sure that we're all supporting that member in that care that's necessary. The last piece here that I'll talk to is essentially how is this going to solve from the obstacle to potentially pushing it down to a solution and or what that may look like. I think mine may be frozen. Allison, are we on the next slide? Perfect. There it is. I had a delay. So the CalAIM funding to address organizational pain points. So of course, every organization is going to have different pain points based on geographics, based on the membership that they're serving. But now, strictly related to CalAIM funding, we want to really focus on these four that we see critical in the aspect of all lines of business, in the aspect, not true lines of business, but lines of business as far as within the healthcare industry. So we have the enhanced billing opportunities. So this is directly related to developing the strategies and workflows to make sure that the providers and the delivery ECMs are capturing the utilization of the Z codes or the social determinants of health, documenting those appropriately, and then relaying that information back up to the plan so that we can make sure that we have that closed feedback loop. Member identification and risk stratification, briefly touched base on that on the prior slide of making sure that we're really enhancing the data analytic capabilities to identify these members. So, typically we'll get a mass list of membership that says, hey, here's your CalAIM members that are eligible. Connecting those members to the right source and the right entity is going to make the largest impact and change to that member's behavior and also to the delivery system too, for us to know how can we best care for that patient, what resources are going to be available, how can we connect them, and then again, relaying that back to the Z code that's going to come back up to make sure that we're documenting appropriately. So member identification is really identifying and having a clean, consolidated piece as much as possible that we all know of a plan of attack on how to make sure that we're best caring for those patients. Improving staffing and clinical competencies on your bottom left is something that's really critical to establish and pop up that infrastructure quickly. So as Evan was talking earlier, we have so many folks on this call that may be in different stages of the CalAIM process. Regardless of where that's at now, popping that infrastructure up now so that we can have a developed policy and procedure and department, however you want to look at or what your need is, so that it can last the process of the CalAIM program is really critical. And developing the training programs and making sure that we have the right staffing in place, making sure you have the right positions that are in concert with that staffing, so we're not misaligned people's skill sets, is something that can really help impact and drive success with that vulnerable population. Because the last thing we want to do is finally get a hold of one of those members that have been, unable to reach for months and months, and then we have the wrong person on the phone. We want to make sure that alignment is there for everyone. Now, the engaging effectively with community partners, again, is at the core component of the CalAIM process, and we've talked about it, more and more, and we'll continue to talk about it because it is alignment of making sure that we have the right people with the member. So for those that don't engage with ECM or not a direct ECM provider, it's the connection and that point of identifying and getting them an ACM provider that's going to work well with them. So a lot of that is looking at the capacity, the volume of ECM and scalability based on population, identifying, how can that connectivity happen? When you are outreaching to my members, how am I going to know about it? In what ways is the coding going to come to me? Making sure that all of those critical components are aligned within that infrastructure so that in theory, you're going to have a process from end to end. That life cycle is going to be clean and smooth. As again, always with the caveat, with as much as possible. There's always, different hiccups that come through, but, looking at what questions to ask from the onset, how can it get structured and built in a way that makes sense so that when the membership starts to flow through and the patients start to take advantage of all of the services that are available to them through the CalAIM process and program, they're available, they're timely, they're direct and straightforward. The patient understands how to contact, who to contact, and what's going on with this third party, now reaching out to them as far as a community health worker. So the program is really just rounding everything out and allowing us to deliver that super specialized patient care for the vulnerable population. That's the piece that I'm going to talk to now. Next, I'll pass it off to Carlene for all of the medical management pieces.
Hello. As we're going to, in this section, connect all the dots, the pieces that Evan spoke about the process for CalAIM, the connection with the provider and the community-based organization. But now we're talking about the member or the patient. As we have a great opportunity to bridge the gap to quality of care in CalAIM. And as we look at this graph, we see what everyone on this call probably knows already. 50% of our patients that has a provider visit will have their gaps closed, quality gaps closed, where we're compared to 15% of gap closures for those patients who don't see a PCP. That's not news to any of us. But if our providers are engaged with ECM services, we have developed workflows with the community partners to work through how we are going to culturally and linguistically connect with the patient. And we can engage them, screen them, and increase engagement with their provider community and make sure that they're seeing their PCP so we can improve either scores for the providers and the health plans that are associated with that group. Right. Codes and billing and documentation. Garrett talked about that earlier. It enhancing and use of the Z codes and SDOH assessments with our population is important to provide total person care and develop total person care plans that is incorporated with community support, referrals, and CHW service. We have a long list of Z codes. This is just a short list that we will use and can use for addressing SDOH's assessment and care and gaps identified. Some of the takeaways, and unlike Garrett, I'm not a lengthy talker. I get to the point and we can discuss the questions after. So I know I'm moving a little bit faster than my two associates, but that's the difference in how we operate. Key takeaways from this discussion and how to uplift the value-based performance and increase revenues through CalAIM. Some of that CalAIM will provide indirect support for indirect impact on the population, like funding infrastructure, translating services, risk arrangements, helping you to build data and analytics structures, risk stratification tools, as Garrett said. And with this, we'll decrease total cost of care for our members and improve quality of performance and outcomes for our providers and our members in value-based arrangements. And the third piece of CalAIM is gap closure. And as you improve total cost of care, as you engage your patients, you will increase gap closures with our providers. And our next slide. How do we leverage CalAIM dollars to fund infrastructure? You can partner with Hope Health Solution. We are a TA vendor, and we can help you to navigate through the marketplace and apply for DHCS funding. My apologies. We can also help you in developing individual statements of work for collaborative work for TA services with the clients, and CHS will help you to initiate client projects through DHCS funding approval. Next slide. And we're going to give you time for question and answers. Feel free. Any questions?
Right. And we have one question we have a few questions in the chat. We'll start with, can we have a list of the health plans already involved in ECM services or CalAIM?
Absolutely. I can do that. So Allison, there's actually a good article that might be helpful we can share from the California Healthcare Foundation that provides a list of the managed care plans per county. And again, that's a great place to start to understand, again, which of the plans that are overseeing these services in each of those areas. We can share that after this program. Absolutely. Perfect.
All right. And our next question is, what are the timelines to apply for TA funding?
The next thing is the technical assistance funding is on a rolling basis. So again, there's no windows. Some of these, for instance, have deadlines. TA funding is on a rolling basis, and it's going to continue for a couple of more years. And so we're happy to reach out to folks if you have questions about specific needs. Does a project qualify? Is there funding available for these services? We can help you navigate that. And likewise, with the process to apply as a recipient of those PATH dollars in the marketplace. So happy to reach out if folks have any questions. Feel free to contact us either through email or phone.
Perfect. And I know you slightly touched on this, but who's eligible to apply for TA funding is our next question.
Absolutely. So other than managed care plans themselves, pretty much everyone can apply for these funding. There's a long kind of footnote at one of the slides that talks about who is eligible. But again, you could be an IPA, a community organization, an FQHC, you could be CBO. These funds are really meant to help bridge some of the gaps that may not be available through other mechanisms in terms of planning, implementation. It could be training, for instance. And so the next thing is there's a wide array of dollars available. And again, a wide net of folks that can apply for these services.
Perfect. In addition to compliance and reporting, what do you estimate the financial impact will be for us with respect to properly recording the Z codes or not?
Sure. So I'm not sure if the question means the financial impact in terms of revenue or the effort required, Z codes are going to be helpful to document through your claims what are the social determinants so that you know and you're able to share with the health plans and put into place a single area. Oh, revenue. Perfect. So right now there's not a dollar for dollar impact on just documenting the codes themselves. However, where you're able to improve documentation for services, what's really important here is one, learning how to bill and document for services overall, but two, as we're able to document more Z codes, that is going to feed into risk scores for the population over time. So as managed care plans in the states are looking at the premium dollars for the population, the more information they have about individuals, not just their chronic conditions and history and physical, but also their social determinants are going to feed into how those premium dollars are shaped as they look at the premium models across the regions in California. So being able to have that information available for both managed care plans and the state is going to be critical to building a better picture of individuals and what is their kind of comprehensive and total risk for those individuals.
And as you add Z codes to those assessments, it increases as Evan said, the risk stratification of the member. It also allows you to give broader care to that member, and so that you can engage them with the providers and increase their compliance with medical care, not just giving the health plans a different risk score, but actually using your ECM service and your community services to improve compliance with care, therefore increase their decrease their total cost of care and increase your quality gaps closures.
And maybe the last thing I'll add is that by documenting Z codes, you're helping to create an information base that will help managed care plans understand these individuals are eligible for these services, right? Unfortunately, claims data, right, doesn't typically document, for instance, homelessness. And so as we complete these surveys and capture this information, it's going to be helpful to make sure that we can then make the case for individuals being eligible for these services. So if you are an ECM provider, it's going to help you get more folks enrolled and increase that direct revenue. If you are coordinating with an ECM provider, it's going to help you provide those services for your members, which is ultimately going to help improve overall total cost of care spend at the MLR, but also achievement of those quality incentive dollars under those value-based arrangements. Great question.
Thanks, Evan and Carlene. All right, our next question is, any idea if there are any bulletin applications that can scrap the EMRs to capture the Z codes? Scrape the EMR.
So if the question is, there are platforms that can help screen a combination of clinical encounter data in the EHRs, care plans, to be able to take that non-standard data to identify if, for instance, in the documentation, did a member mention, for instance, food insecurity or access to transportation issues. So there are platforms available on the commercial market. What I would suggest is, as you talk with ECM providers, but also your managed care plans, some of them have been engaging with vendors to learn more about solutions, do some pre-vetting. And likewise, happy if folks have specific questions around that capability, we can reach out and provide you with some insights into who might be a good vendor for that service.
Just reading one more question. All right, so in regards to your previous answers, the individual is wondering if tools like Interqual and Milliman will be adapted to help us better IP criteria for them, giving their high-risk living conditions and difficulty to keep them healthier when they're away from our care.
So I would say you should send those to Interqual. Yeah, the answer would be ideally yes, right? We want to see more of the commercial applications incorporating social determinants of health. We know that, for instance, if folks are following what CMS has been doing, right, with ACO REACH, as well as the AHEAD program, making the ability to track and document social determinants more important to risk stratification, as well as the funding models. And so again, as those commercial groups are able to incorporate that information into their risk models or predictive analytics, that's going to be critical. And likewise, at the local level, folks would be able to adapt those risk stratifications into their own platforms and analytics. And that is one of the areas that the state is willing to fund that will help you better be able to screen available data, even in your own community, in your own market, or your own patient population. So we like to see both of those happen. Absolutely.
Thank you, Dr. Marca, for your questions. And Dr. Marca says thank you as well. What other funding can a provider or ECM provider apply for aside from TA funding?
Absolutely. So again, it's going to depend on how the provider wants to engage in CalAIM. So let's say that if you look at the requirements to be an ECM provider or to engage in delivering community support, to say, you know what, that's not for me, it's not my core business model, but you want to be able to coordinate for those services, that's certainly available to you. If you go down the path, though, of providing ECM services, that's going to put you on a track that allows you to work with your managed care plans to access those IPP dollars. Likewise, be able to utilize those TA services and funding through the PATH marketplace. Again, if you're not going down that path, one of the other programs that's just now launching and the application will be due at the October 22nd is that Equity and Practice Transformation Funds that again will be part of a long-term transformation program the state's going to drive with managed care plans for those small practices. And so that's another example of those funds available. And then lastly, that community health worker benefit, which is not dollars being provided, but enables you to quote unquote prescribe those services for your members. And again, that's going to really help engage and create that alignment with community organizations that are extending those CHW services and make that part of the daily practice.
All right, and we have another question, which is, if I'm not a certified ECM provider and I currently do not have partnerships with any ECM providers, how do I connect with an ECM provider?
My recommendation would be to reach out to the health plan. So depending on the county that you're in, the health plan is probably the best resource to identify who are the ECM providers in the market. Second is, if you go to the PATH marketplace, there are a number of regional and collaborative meetings happening per county that you can engage in and participate in, and that'll allow you to meet additional stakeholders and providers in the community. And so I'd recommend, lastly, the CalAIM webpage, which we'll include as part of the follow-up, also has a number of meetings that are available for stakeholders that maybe want to just watch and learn and listen that are occurring in communities and counties across the state. And again, that's where you'll see a lot of those ECM and community support providers engaging, and so you can make those connections likewise through those collaborative forums.
And I think that's all of our questions in the chat.
Wonderful. Well, I want to thank everyone today for joining with us. We'll include, again, the presentation as well as the recording and some additional documents mentioned earlier. I want to thank my co-panelists and hope everyone has a great afternoon and a safe weekend.